we will start with the pharynx. So what is pharynx? Can anybody tell me what is pharynx? It is also part of the digestive tube. It's a commencement of the esophagus. That is, this is a funnel shaped area that is present against the nasal cavity, oral cavity and the larynx. Okay. So accordingly it can be divided into the nasal cavity. Against the nasal cavity there is a nasopharynx. Against the oral cavity that is the oropharynx, and against the larynx, laryngopharynx. So it is continued in that way. It has got roof. We can get the roof here. That is a basi-sphenoid, basi-occiput. You know that is the undersurface of the skull. That area. This forms the roof. And also we can create the anterior arch of the atlas, and we can get so many vertebrae up to the 6 cervical vertebrae. So that is the extent. Whereas this is the nasal cavity. Against the nasal cavity we can get the atlas and the axis, the second cervical vertebra. Against the oral cavity we can get part C3, C2 and C3. We will get part of the C3 vertebra. And in the laryngopharynx, that is against the part of the C3 to C6 cervical vertebra. And there is a constriction, most constricted part of the digestive tube, that is the cricopharynx, which is at the level of C6 vertebra. Actually, within the pharynx we can get some circular or constrictor muscle, and innermost 3 we will get the longitudinal muscles. The lower, the outside we are getting the circular muscles. Those circular muscles, they are named as superior, middle and inferior constrictor muscles. Like we have seen the buses, small bus, medium bus, larger flower bus, or bucket, small bucket, medium bucket and larger bucket. You can assume the larger bucket is the inferior constrictor, then the middle, then the superior one. They are placed like this. Flower vase or the buckets, one in another. So they are the constrictor muscle, and the lower one is the inferior constrictor. So inferior constrictor muscle, it takes origin. We cannot see the thyroid cartilage, cricoid cartilage. It originates from thyroid cartilage and the cricoid cartilage, and it goes back, and so it has got thyropharyngeus and cricopharyngeal part. So that cricopharynx, the cricopharyngeal part is the most constricted part, where we know this is the most constricted part of the digestive tube. So we must remember that one. Now these are the parameters: length, a funnel shaped area, there is more extended area in above, and a lower part it becomes tubular. So, and location, pharynx is located against the nasal. The same thing what I am saying, that is the against the nasal cavity, against the oral cavity, against the larynx. The lower border of the C6 vertebra is the junction between the pharynx and the esophagus. So what I have said, that is superiorly the base of the skull, posteriorly we can get inferiorly esophagus, posteriorly by prevertebral fascia and the vertebra. Okay, inferiorly it is continued with the esophagus. So we can find the subdivision nasopharynx, oropharynx and laryngopharynx against the nasal cavity, oral cavity and larynx. What is larynx? Larynx is the voice box. The commencement of the trachea, before we can get the larynx in the commencement of the trachea, that area which helps in production of voice, sounds. Okay. During voice is, we can create voice during inspiration or expiration. Expiration. Air is coming out and there is a string like structure which is called rhima glottis, and it vibrates and the voice is emitted. And ultimately there are some articulating area, that's a mouth, tongue, teeth, pharynx. They it helps in articulation of the sound. So this is the area, you can see this is the area, this is the funnel shaped area above, and this is the, we can find this is the nasopharynx, oropharynx, and against the larynx, this is the laryngopharynx. So we can find this picture, this is a nasal cavity, oral cavity, we can find this funnel shaped area. And we can find it is been limited by some structures, like nasopharynx is limited by this structure. This is the hard palate which becomes soft palate behind. So this soft, the above is formed by this is the upper limit of the nasopharynx is formed by the undersurface of the skull. That is the sphenoid, basi-occiput and occipital bone. So this is the basi-occiput and basi-sphenoid, they are forming, and also the arch of atlas, anterior arch of atlas. And lower limit is formed by this soft palate. So this area, that is the soft palate and the posterior pharyngeal wall, this is the area which we call is as a aperture, which we call is as nasopharyngeal isthmus. Or here you can, the same thing we can see, this is the area, this is the soft palate and this is the posterior pharyngeal wall. So this area is called the nasopharyngeal isthmus. So this is the area of nasopharynx which is limited below by this soft palate. Actually in the second stage of deglutition, that means during swallowing, what happens? Food should not enter into the nasal cavity. Should it enter? খাবার কি nasal cavity তে যাবে, যেতে দেবে? No. So that is been prevented by one mechanism, that this soft palate becomes straight and goes behind. And there is also a muscle which is called the Pharynx muscle, which forms a ridge, and this area gets blocked. That is called nasopharyngeal isthmus. Similarly, in front, in the oropharynx, we can find this oral cavity, okay, and the communication between the oral cavity and the oropharynx, this area is called oropharyngeal isthmus, which communicates with each other. Okay, so during second stage of deglutition, we can find this is the, we can find the tongue here, okay. Tongue is being raised by some palatoglossous muscle, we know. Palatoglossous, palatopharyngeus, there are several muscles. Stylopharyngeus muscle. So ultimately this tongue is elevated and this area gets blocked in second stage of deglutition. In the first stage of deglutition, actually the food remains within the oral cavity. In the second stage, it goes back. Okay, so during its journey, food should not enter into this nasal cavity, or it should not come back to the oral cavity. So this area is also get blocked by elevation of this structure, that is the tongue. So that is the nasopharyngeal isthmus and oropharyngeal isthmus gets blocked. So this is the mechanism. So we can get nasopharynx, oropharynx and laryngopharynx, and you can see this is the lower limit of the laryngopharynx, which is at the C6 or 6 cervical vertebra, where it is continued. We can see this is this is the lower limit of the oropharynx, which is continued. This ছবিতে গন্ডগোল আছে, ঠিক আছে? Okay, this is the larynx. This is not the laryngopharynx. This is the laryngeal cavity. Against this is the laryngopharynx. Okay, this is not. This is the laryngopharynx. If it is lower border of the C6, it is the lower limit of the pharynx, and this is the esophagus. C6 vertebra. Second, third, fourth, fifth, sixth. So this is the lower limit of the pharynx. From there, it is continued as esophagus. This is, and behind, in front, we will get the trachea. So this is very important picture or figure where we can see the lateral wall of the nasopharynx. Here we can get, and we can get the posterior wall, which is formed by this anterior arch of the atlas, and the second, we know the odontoid process or dents of the second cervical vertebra. So this area is we are getting the nasopharynx. Here we can get on the lateral wall opening of the pharyngotympanic tube. The connection between the middle layer and the pharynx. So that is the opening of the pharyngotympanic tube, and which is being, and around which we can get an elevation. Okay, that is called tubal elevation, and within the tubal elevation we can get some lymphoid tissue, that is called tubal tonsil. So these are the structures, very important structures, what we can see in the lateral wall of the nasopharynx, which is quite evident in the sagittal section. Okay, in the sagittal section we can get the opening of the pharyngotympanic tube. Pharynx, one end is in the pharynx or the nasopharynx, and another end is tympanic cavity, that means the middle layer. So this is a communication. So it maintains the air pressure on the either side. Okay, so that too is we can get an elevation. That elevation is contributed by some lymphoid tissue, which is called tubal tonsil. There is palatine tonsil. We can get tubal tonsil. Okay, we can get another tonsil here. Okay, just on the undersurface of the base of the skull, we can get another tonsil or lymphoid tissue, which is called adenoid, which is very much prominent in young child. That is called adenoid. Can you remember? So that is, we can also call it as a pharyngeal tonsil or the adenoid. So we are getting so many tonsil. One is tubal tonsil over the pharyngotympanic tube. We are getting lymphoid tissue or tonsil, which is the pharyngeal tonsil, and we can get another tonsil here. We can get, this is the tonsillar fossa, this is the palatoglossal and palatopharyngeal fold, where we can get the tonsil. This is the area, this is the tonsillar fossa. And also we can get another tonsil over the posterior one third of the tongue. Okay, some tonsil, this is the lingual tonsil, this is the palatine tonsil. Okay, so there are so many tonsils and they forms a ring-like structure which is called Walde's ring. Walde's ring. So this is very important. This forms the first line of defense. So in the nasopharynx we are getting this. Now we can get the oropharynx. This is a cumbersome picture, but still you can get it. This is the soft palate. You are seeing this is the posterior pharyngeal wall, and also the esophagus is being cut, and we can find this is the pharynx, okay, and this is the larynx, and this is the area where we can get the base of the tongue, and if we go inside we will reach into the oral cavity, and this forms the one boundary which is formed by the posterior end of the soft palate, where we can see the uvula, and here we can get another limit which is being contributed by upper border of the epiglottis. So this is the area which is the area of the oropharynx. So oropharynx is limited above by the soft palate, below by the epiglottis, in front by the aperture which is called oropharyngeal isthmus, and behind by this posterior pharyngeal wall. Okay, so this is the oropharynx, and also we can see we can appreciate the laryngopharynx. This is the inlet of the larynx. Okay, and behind which we will get, this is the pharyngeal wall which we have cut open. This is a tubular structure. So the part of the pharynx against this laryngeal cavity is the oropharynx. Here we can find so many things, like we can get the limit of the lower limit which is contributed by the cricoid cartilage, and above which we can get the arytenoid cartilage, and we can get other two cartilages, cuneiform and corniculate cartilage, and from here we can get a fold, mucosal fold, which is continued up to the epiglottis, to the arytenoid cartilage, which is called epiglottic fold. Why I am saying so many complicated terms? Because I want to impress the inlet of the larynx, which forms the anterior boundary of the laryngopharynx. So this opening is very important, because we have to locate, and we have to be very much familiar with that opening, because in ICU what we do, intubate a patient, so that we have to know which one is the inlet of the larynx. We have to intubate within this cavity. Okay, this is laryngeal cavity. So we must search, behind is the esophagus. The tube must pass through this laryngeal inlet. So during your duty in the ICU, you have to know which one is the laryngeal inlet, which one is larynx, which one is pharynx. Otherwise, you will put the tube in the pharynx or in the esophagus, or Vice versa, that means Ryan's tube is which should be within this esophagus. You can put it here in the larynx, and you can start feeding the patient, and the patient will die immediately. So you have to know which one is the laryngeal inlet, which one is the pharynx. Pharynx, that means that is the laryngopharynx. So this part we can call this as a laryngopharynx. And lower one of the cricoid, it forms the boundary between the pharynx and the esophagus. So within the oropharynx, what we can see we can see the palatine tonsil, we can see the uvula, we can see the base of the tongue. So this base of the tongue forms the anterior limit, and this is the lower limit is contributed by the epiglottis, and we can find this is the laryngeal inlet. Okay, and there are so many folds. One fold from epiglottis to the arytenoid cartilage, aryepiglottic fold, which virtually comes closer during deglutition, and it shuts down the inlet of the larynx. So this is the oropharyngeal isthmus, the entry point from the oral cavity to the oropharynx. We can find there are two folds. One is palatoglossal fold, we can find, okay, there is the palatoglossal fold in front and another fold behind, which is the palatopharyngeal fold, and in between we are getting the palatine tonsil. And you know, during second stage of deglutition, tongue is elevated and this area gets closed. Okay, so the food goes into the oropharynx and it is not been carried out to the oral cavity anymore. Similarly, the nasopharyngeal isthmus is also closed at the same time. Reflexly it is done. Okay, and food bolus ultimately passes to the laryngopharynx and ultimately it reaches the esophagus. Laryngopharynx, we have seen that this is the area of the laryngopharynx. Now what is pyriform fossa? We can see this area is the pyriform fossa. This is the aryepiglottic fold. This is the epiglottis and this is the aryepiglottic fold. Okay, and laterally we can get another area between the hyoid and the hyoid bone and the thyroid cartilage. Okay, which covers the hyoid bone and the thyroid cartilage, which is called thyrohyoid membrane. Okay, so laterally we are getting the thyrohyoid membrane, okay, which can appreciate in the viscera very nicely in between hyoid bone and the thyroid cartilage, which are not visible in this figure, but laterally the lateral limit is by the thyrohyoid membrane, medially by this aryepiglottic fold, and above we are getting the glossoepiglottic fold. Okay, so and this is the area which is called the pyriform fossa, because here what we can get, the fish bone gets lodged here, and also the smugglers can conceal some jewelry in this pouch. They can increase the depth of this pouch. The pouch is the pyriform fossa is small, but they know the technique how to increase that area so that they can keep the jewelry in that area, and during requirement, they can take it out. So that is the smuggler's pouch. This is called the smuggler's pouch. And this area is being innervated. We know this is the lateral part, that is the thyroid membrane, which is being pierced by this internal laryngeal nerve. Okay. So during the operative procedure or the daycare procedure by which we take out the fish bone from this area, we should be very much cautious, because we may damage this internal, we may damage this nerve, which is called the internal laryngeal nerve. Perforation, damage, internal laryngeal nerve. So these are the, this is not a very good figure, but you can, but this is the, what should I say, more or less sagittal section. Okay. Sagittal section of the pharynx, where we can get most inside is the mucous membrane. Then we are getting one layer which is continued up to the base of the skull, which is called the pharyngobasilar fascia. Basilar part of the occipital bone, that is continued up to this area, that is the basilar part of the occipital bone. One fibrous layer is continued, that is the pharyngobasilar fascia. Okay. Then we can get submucous layer, and then we can get this muscles, three muscles. One is superior, one is middle, and inferior. I told you they are like small, medium, and large vas fitted inside. And in this figure, the longitudinal muscles are present in front, which is missing in this figure. Okay, there are three longitudinal muscles. I will discuss. Then behind we can get another, that is a buccopharyngeal fascia. So this is from inside to outside. This is the orientation. So this is a very good picture where we can see the superior, middle, and inferior constrictor. You can see superior constrictor, it is taking origin from the sphenoid. We know that is a sphenoid bone. Within the sphenoid bone, that is pterygoid plates. Have you seen the sphenoid bone? So it has got medial and lateral pterygoid plates. Okay. From the the posterior border of the medial pterygoid plate, okay, we can find this is the posterior border of the medial pterygoid plate. From here it is taking origin. And the medial pterygoid plate has got one hamulus or hook-like structure, which is called pterygoid hamulus. So that is pterygoid hamulus. From there, the pterygoid hamulus is connected with the mandible. So that is a ligament which is called actually pterygomandibular. It is called pterygomandibular raphe. This is not pharyngomandibular raphe. This is wrong. Pterygomandibular raphe. Okay. So that is present, which is attachment is inside the mandible. Here is the mandible, and we know the mylohyoid line. So it is present up to the posterior limit of the mylohyoid line, and from the also from the posterior part of the mylohyoid line. So this is the origin of this muscle, and it gets inserted over. We can see this is the undersurface of the base of the skull. We can find this area. This is an area through and through. All these muscles goes up and up to, this is the pharyngeal tubercle, which is called. So ultimately this is, and in the midline, which is the pharyngeal raphe. So that is the insertion point. The next one is the middle constrictor, which is taking origin from the, we can see that greater cornu of the hyoid bone and also from the lesser cornu, and it goes back and it is inserted into the pharyngeal raphe and the pharyngeal tubercle. The middle, this is the middle bucket. You can assume this is the middle bucket or the middle flower vase, and this is the biggest flower vase, that's the inferior constrictor, which is taking origin from the oblique line of the thyroid cartilage and also from the cricoid. So it has got thyropharyngeus and cricopharyngeal part. Cricopharyngeal part is the constrictor. If anything, like whether it is a fish bone or anything, if it can pass this cricopharyngeal part, then it can go safely anywhere. Okay, it can come out through the digestive tube. Okay, so that is the thyropharyngeal and cricopharyngeal part. Okay, that is the inferior constrictor. So same thing, more precisely you can see the origin and the insertion. So there are three side by side, you must know, this is the hyoid bone, this is the thyroid cartilage, this is the cricoid cartilage. So part of the larynx you can see. Okay, so the cricopharyngeus and this is the thyropharyngeus. So this whole muscle is inferior constrictor. This is middle, this is the superior one. Now there are some structures which passes in between these muscles. Okay, you can find this is the base of the skull and this is the superior border of the superior constrictor. This area is blocked by the pharyngobasilar fascia. Okay, pharyngobasilar fascia, the triangular area. This is called the space of Morgagni, sinus of Morgagni. And through that area we can get two vessels. One palatine branch of the ascending pharyngeal or ascending palatine branch of the facial. So two arteries we can find here. And they pass through this sinus of Morgagni. And we can find one tube, that is pharyngotympanic tube, eustachian tube, which communicates the middle ear and the pharynx. So within the sinus of Morgagni we can find two tubes also. Okay, that is the auditory tube, eustachian tube or pharyngotympanic tube. Okay, and also we can find one muscle which passes through this area, which the function is levator, elevation of the palate, the soft palate. The hard palate you cannot lift. Hard palate ki tumi তুলতে পারবে? পারবে না। So only the soft palate. So levator veli palatine. Okay. So that muscle also passes through this area. So this is the sinus of Morgagni. And now we can get superior and middle constrictor, through which we can get one muscle and nerve. And this nerve is exclusively for this muscle. This muscle is stylopharyngeus. This muscle is coming from the third branchial arch. Is coming with only one muscle for the third arch, that is the stylopharyngeus, and it carries its own branch, that is the glossopharyngeal nerve. Okay, the only muscle of the third arch which is supplied exclusively by this glossopharyngeal, that is passing in between superior and middle. And we can find this is the hyoid and this is the hyoid bone and this is the thyroid cartilage. In between what we can get? thyroid membrane we have seen in the cadaver. What nerve is entering? Internal laryngeal. So, in between middle and inferior we can get the internal laryngeal nerve and superior laryngeal vessel. Nerve is above the artery or vessel. Nerve is always above. Superior laryngeal vessel. Superior laryngeal vessel is coming from superior thyroid artery in the cadaver we have seen. So it pierces the. Now we can correlate. At this stage you can develop your ability to correlate with the cadaver and the viscera. So that is the internal laryngeal nerve and superior laryngeal vessel. Whether the inferior constrictor will get deprived? No. This is the inferior constrictor. See, it will not get deprived. We can find another vessel and nerve that is kept for the inferior constrictor. That is recurrent laryngeal nerve, which is found in between this is the esophagus and this is the trachea. In between we can get this recurrent laryngeal nerve and inferior laryngeal vessel. We can see whether internal laryngeal or recurrent laryngeal, these are all the pharyngeal branches of vagus. We can find this internal laryngeal, we can get the external laryngeal, actually coming from the superior laryngeal, they are coming from the vagus nerve. And recurrent laryngeal is also coming from the vagus, but it is coming arching the on the left side. It arches the arch of the aorta, recurrent laryngeal, ligamentum arteriosum. So ultimately it reaches the tracheoesophageal groove and ultimately it reaches the larynx. So this is a Jenker's diverticulum between the clinical entity we know thyropharyngeus and cricopharyngeus. In between we can get a diverticula and weak spot that is called Killian's dehiscence, through which we can get a Jenker's diverticulum, and is a clinical entity. Why? Food may get chronically collected and decomposed. That will create a problem. So it is a clinical entity for the cardiothoracics or the head and neck surgeons. Now, outside we have seen all these muscles, that is the superior, middle, inferior, but inside we are getting three pharyngeal muscles which help. These constrictor muscles, they actually constricts, and they are basically they help in propagation of the food. So there are some longitudinal muscles which are present inside. One is coming from the palate, one is coming from the that is a pharyngotympanic tube. There is the interstitial tube which is called salpingopharynx. So there is a salpingopharyngeus, and another is coming from the palate. One is coming from the palate, one is coming from the eustachian tube, one is coming from the styloid process of the temporal bone. Stylopharyngeus, salpingopharyngeus, palatopharyngeus. Okay, the three muscles, and they get inserted at the posterior border of the lamina of the thyroid cartilage. So they help in propagation of the food. All the muscles of the pharynx are supplied by, this is the motor supply is by, they actually develop from the myotome of 6 branchial arch. whose nerve supply is cranial accessory. Okay. Actually, the recurrent laryngeal nerve definitely, but it carries the fibers of the cranial accessory. So, all the muscles of the pharynx, they are supplied by cranial accessory through pharyngeal plexus. Pharyngeal plexus we can get in between the constrictor muscles, and that pharyngeal plexus means a plexus of nerve which is been contributed by cranial accessory, which is been contributed by the a branch from the glossopharyngeal and also a branch from the cervical sympathetic nerve. So that is called pharyngeal plexus. From there we are getting, except stylopharyngeus, because stylopharyngeus is supplied by glossopharyngeal nerve, is a muscle of third arch. Okay, just remember this much. বেশি আর যাব না। আচ্ছা, আর্টারিয়াল সাপ্লাই কি আর বলবো, ফ্যারিংস এর মধ্যে তোমার যত অ্যাসেন্ডিং ফ্যারিঞ্জিয়াল আর্টারি, branch of the first branch of external carotid, ascending pharyngeal. There are all the vessels that is coming up, that is the facial artery is there, lingual artery is there. They are all where we will get the branches contribution to the pharynx. Okay. And venous drainage is the pharyngeal plexus. Okay, ultimately it is drained into internal jugular or facial vein. এখানে কি ভেন আছে, এখানে ইন্টারনাল জুগুলার আর ফেসিয়াল। আলটিমেটলি ফেসিয়ালে পড়লো ইন্টারনাল জুগুলারই ফেরত আসবে। It will drain into, first it will drain into the facial, then it will enter into the internal jugular. So pharyngeal plexus. Lymphatic drainage of the pharynx to very obvious retropharyngeal and deep cervical lymph nodes, we know. So degradation আমি যাব না, আলাদা ক্লাস। Now I will show you the larynx, the cartilage of larynx. First, I will show you the cartilage of larynx. Okay, unless already we have seen the thyroid cartilage, cricoid cartilage. আরে এটা দেখে নাও, আর কি আছে, larynx এর বেশি কিছু নেই। larynx এ cartilage আর muscle একদম ছোট। So you can see this is the outline of the larynx which has been contributed in front by this cartilage, that is thyroid cartilage, Adam's apple, which prominent in male. Okay, then we can get the cricoid cartilage or anterior arch, which has got posterior arch. Okay, and we can get the hyoid bone. This is the thyroid membrane, where we can, so the next figure we can see, this is the epiglottis. There are so many cartilages. There are three unpaired laryngeal cartilage. One is epiglottis, one is cricoid, and one is thyroid. Epiglottis, thyroid cartilage, and cricoid cartilage. They are the three unpaired cartilages. And what are the paired cartilages? We can find just over the cricoid, in the posterior, this is the posterior lamina of the cricoid, over which we can get the arytenoid cartilage, over which we can get the corniculate and cuneiform cartilage. They are basically present within this fold, which is called aryepiglottic fold. Within the arytenoid and the epiglottis, this is called aryepiglottic fold, within which we can get corniculate and cuneiform cartilages. So this is the picture by which we can find this is the thyroid cartilage. This is which has got, we can find this lamina, and there are superior and inferior horn. The inferior horn forms a joint with the cricoid cartilage. It's a synovial joint, cricothyroid joint. Okay, and here we can get cricothyroid membrane, and this is the thyroid membrane. And here we can find over the membrane we can get cricothyroid muscle, which actually when contracts, the thyroid cartilage comes forward, and when it contracts from above, actually this cricoid cartilage is tilted backwards. So there are some things there are some ligaments we must remember. That is the medial thyroid ligament. The thyroid membrane gets condensed. Medial thyroid ligament, lateral thyroid ligament, in which we can get another cartilage. This is the cartilagotriticea. You may forget it, no problem. But this is the cricothyroid membrane, which is thickened in the middle, which is called cricothyroid ligament, or it is called conus elastica. And then between the cricoid and the first tracheal ring, cricotracheal membrane, which also forms a ligament. So these are some external ligaments. Now this is the picture of the epiglottis, thyroid cartilage, arytenoid cartilage, and cricoid cartilage. This is the apex of the arytenoid cartilage, and this is a process. It looks like a pyramid or একটা সিঙ্গারা দেখেছো সিঙ্গারা যেরকম উপরে চূড়া আর দুটো প্রসেস থাকে একটা প্রসেস কল্পনা করতে পারো বাইরের দিকে that is muscular process আর একটা সোজা that is the vocal process. So it has got three processes. One is muscular process, one is vocal process, one is apex, and there is the connection between the cricoid cartilage and the arytenoid, the crico-arytenoid junction, and over which we can get these two cartilages, corniculate and cuneiform cartilage. So the thyroid cartilage with the thyroid cartilage, upper border, lower border, anterior border, oblique ridge, and it can find the posterior border, and this is the upper horn, lower horn. So in the oblique line we can get the inferior constrictor muscle, we can get sternothyroid, thyroid. So these are some muscles which are attached there, and inside the thyroid cartilage we can get so many attachments. These are the attachments of some ligaments. Thyroid to epiglottis, thyroepiglottic ligament. This is the vestibular ligament. This is the vocal ligament. This is the posterior lamina and anterior arch of the cricoid cartilage. Cricoid cartilage from this is the side view. We can see this is the posterior view. Epiglottis we know this is the anterior surface, this is the posterior surface we can find, and this is the right lateral surface. Now, there are some ligaments in between the epiglottis. Actually, this is a fibrous structures which connects the cartilages of the larynx. In between this is epiglottis and this is the epiglottis, this is the thyroid cartilage, this is the cricoid cartilage. And if we see the interior of the larynx, we can see there are three regions. This is one region, this is another region, and this is another region. This above region, this is called a vestibule, where we can get a quadrangular membrane from inside outside. Mucous membrane, submucous coat, then fibrous coat, then muscular coat. What we can see, this is a fibrous coat. This fibrous coat, what we are getting, is a quadrangular shaped fibrous coat, and this is which ends in a ligament which is called vestibular ligament, and this area is called quadrate membrane, and below this area we are getting another ligament which connects the vocal process and the thyroid cartilage which is called vocal ligament, and below which we are getting another fibrocartilaginous part which is in between the vocal ligament and the cricoid cartilage. Okay, so this is called conus elasticus. Okay, forget it. Just try to remember this figure. The inside of the larynx, there are three areas. One is vestibular area, which ends in vestibular ligament. Then we can get, this is the area which is called the vocal ligament. This is the cricovocal membrane. Okay, cricovocal membrane is this area. Okay, this is cricovocal membrane. This is the vocal ligament. It is wrongly printed. Okay, the vocal ligament is this one. This is the vestibular ligament. This is vocal ligament, and this is the from cricoid to vocal ligament. This is called cricovocal membrane. Is this one? Okay, remember this one. Now, this is a view from posterior side. This is very good picture. This is epiglottis. This is the muscle. So, one muscle we can find, this is taking origin from posterior lamina of the cricoid cartilage and attached to the muscular process. This is called the posterior cricoarytenoid muscle. This posterior cricoarytenoid muscle, when contracts, there is enlargement of the area in between two vocal folds, which is called abduction. All the muscles of the larynx, remember, they causes the intrinsic muscles of the larynx, they causes, this is abduction, this is adduction. All the muscles causes adduction. So if two vocal folds come very much closer, there will be no entry, there will be no chance of entry of air or exit of the air. Whereas during abduction, there will be entry and exit of air. So only muscle which causes the abduction is this muscle which is called posterior cricoarytenoid. You know, this is the muscular process of the arytenoid. When it contracts, there will be abduction of the vocal folds. Okay. So only abductor is the posterior cricoarytenoid. So this is called the safety muscle of larynx. If this muscle is paralyzed, then the vocal folds will come very much close to one each other. So there will be no entry or exit. The patient will suffer from breathlessness. So this is the only muscle which causes the abduction. Otherwise, we can find another muscle which is continued from one arytenoid to another arytenoid, transverse arytenoid, another muscle from the muscular process of one arytenoid to the apex of the other arytenoid. They are called the oblique arytenoid. So transverse arytenoid, oblique arytenoid, posterior cricoarytenoid, and another muscle we can find from here which is attached to cricoid in front and the muscular process of the arytenoid bone. So this is called lateral cricoarytenoid. So all small intrinsic muscles of larynx are, remember, they cause the adduction, except posterior cricoarytenoid which causes the abduction. So we can, this figure shows the different muscles again. This is the cricoid above which we are getting the arytenoid. This is the muscular process. This is the posterior cricoarytenoid. This is the lateral cricoarytenoid. This is the oblique cricoarytenoid, and this is the transverse cricoarytenoid. And this is the vestibular fold. This is the vestibular fold in which we get the vestibular ligament. This is the vocal fold in which we are getting the vocal ligament. Below that area we can get another muscle which is continued from the vocal process of arytenoid to the thyroid cartilage, which is called vocalis muscle. And this vocalis muscle is also attached to the vocal ligament and causes modulation of the voice. The singers can modulate with the help of this vocalis muscle. This muscle is continued from the muscular process of the arytenoid to the thyroid cartilage, and also it is attached with the vocal ligament or vocal fold. So it can modulate the sound. Okay. So that is vocalis muscle. So this is what I was saying, abduction, adduction. So here we can find, this is the abduction caused by the posterior cricoarytenoid. When it contracts, there will be abduction. Okay. And there will be developed, we know there are two parts. This is the membranous part and this is the cartilaginous part of, and this opening is called the rhima glottis. Rhima glottis, this opening is called the rhima glottis, which has been contributed anterior 3/5 by the vocal fold and posterior 2/5 by the cartilage. Okay. So anterior one is triangular, posterior one is quadrangular. When posterior cricoarytenoid contracts, there will be enlargement of this area and this quadrangular area becomes triangular, which apex is directed back. And reverse happens when there is adduction. During adduction, the area between the vocal folds gets narrowed. Okay, so there will be least chance of air entry in adduction, which is being contributed by these muscles, all other muscles like lateral cricoarytenoid and transverse arytenoid, oblique arytenoid, which causes this adduction, where we can see the quadrangular part becomes triangular and the apex is directed in front. And both transverse and oblique arytenoid, they are all contract. There will be chink of area in between the vocal folds. Okay. So this is the different shape of the rhima glottidis. So we can find this is the vocal fold, this is the vocal process, this is the muscular process. Okay. We can find this is the vocal fold, and this helps in production. Helps in production of voice. These vocal folds causes production of voice during expiration. When air comes out through this area, we can get the production of voice. So anterior 3/5 is membranous, contributed by the vocal cords or vocal folds, and inside which we can get the vocal ligament, and posterior 2/5 is contributed by this arytenoid cartilage, which is quadrangular in shape. You can see all the muscle attached here, only one muscle that is acting posteriorly. So when it contracts, there will be abduction. Otherwise, all the muscles are acting actually the direction of force you can see forward medially. So they will cause adduction. Like lateral cricoarytenoid. This is the thyroarytenoid. This is the vocalis muscle. They are causing the adduction. Then we can get one is tension and relaxation. Tension and relaxation. The thyroarytenoid muscle will cause not only adduction, but also there will be shortening of the vocal folds. So that is the relaxation. Only one muscle which will cause development of tension. This is a cricothyroid muscle. Hey, the only cricothyroid muscle when contracts, we can find this is the thyroid cartilage. Thyroid cartilage comes forwards. So there will be development of tension in the cord. So only tensor is the cricothyroid. এবার বলে দিই, all the muscles of the larynx এইটুকুনি শুনে ছেড়ে দেবো, are supplied by recurrent laryngeal, the motor nerve supply, except cricothyroid, which is being contributed by the external laryngeal, which is coming from the superior laryngeal. Okay, and the sensory supply above the fold, vocal fold, is by the internal laryngeal, and below the vocal fold is the recurrent laryngeal, carrying the fibers of accessories, cranial accessories. তো যাই হোক, কেন বলছি, there are two types of lesion of the superior laryngeal nerve or recurrent laryngeal nerve. So these are the different position of the vocal folds in nerve injury. You can see this is the midline position. If it is in the midline, there will be absolute respiratory difficulty. We can face in respiration. If the two folds comes very closer, there will be respiratory difficulty. If this triangular area is shortened and becomes a linear chunk, what will happen? Air will take its entry or not? Air will not get its entry. It can happen during recurrent laryngeal nerve palsy. Only recurrent laryngeal, all the muscles are supplied by. So it will come in the midline position. Why? This is the cadaveric position and this is the abduction position. When both recurrent and superior laryngeal nerves are affected, like in the cadaver, any supply? In our cadaver, is there any supply? Both the superior laryngeal and recurrent laryngeal, they are inactive. So, the position of the vocal fold will be like this. It is called the cadaveric position. Adduction, when the recurrent laryngeal is affected and superior laryngeal is not is active. When superior laryngeal is also affected, then we can get the cadaveric position. And this is the abduction position and this is the adduction position, what you know already, okay, with the help of posterior picoarytenoid and other muscles of the larynx. So we must see this area. This is the what we can get in the viscera. That is the vestibular area. This is the vestibular fold. This is the vocal fold. In the vestibular fold, we get the vestibular ligament. In the vocal fold, we can get the vocal ligament. And there is an area, depression area. This is the sinus of the larynx. And within the sinus of the larynx, we can get a saccular structure which is called the saccule. This saccule contains oily secretion because the vocal fold, in the vocal fold there is no submucous layer. If there is a submucous layer, that will be dangerous. If there is an edema, the laryngeal edema, immediately patient will die. So nature has not put any submucous layer in this area. So there is no secretion. The secretion is contributed by this saccule and there is a oily secretion. And this area is called the glottis or subglottic area. Okay. So this much you can see in the, so this area is called the area between the two vestibular fold, and area between the vocal fold is the rhima glottis, and this is called rhima vestibuli. And in between we are getting the sinus of the larynx. Blood supply, superior laryngeal, inferior laryngeal vessels we have seen. Superior is coming from the superior thyroid, inferior is coming from the inferior thyroid. The superior will go into the, ultimately it will reach the veins, the superior and inferior laryngeal vessels. Superior one will ultimately enter into the internal jugular. So this is the, clinically we can see this is the vocal fold. We can find this cuneiform cartilage, corniculate cartilage, and here we are getting the arytenoid cartilage. So this is the arytenoid area, and this is the area, this is the rhima glottis. Rhima glottis means in between two vocal folds. Above we are getting the vestibular fold. This is the rhima glottis in between, and this is the vocal folds, and this is the sinus of the larynx. We can find it in the, and this is the pyriform fossa we can get. Okay, we can get the pyriform fossa in laterally. This is the aryepiglottic fold.